Hello, everyone. Welcome back to the Mounties for Freedom podcast. This is episode 2. I know we've had a big stretch in between, but we're back at it. And today I have the absolute pleasure of presenting an interview that I conducted with Dr. Eric Payne. Dr. Payne is a pediatric neurologist and clinical researcher. He worked as a pediatric neurology and epilepsy consultant at the Mayo Clinic in Rochester, Minnesota from 2014 to 2020. He completed medical school and pediatric neurology residency at the University of Calgary and Alberta Children's Hospital. He then pursued fellowship training in pediatric neurocritical care and epilepsy at the Hospital for Sick Children in Toronto. He obtained a Master of Public Health from Harvard University. He is board certified in pediatric neurology. He's a fellow of the Royal College of Physicians and Surgeons of Canada and clinical electroencephalography, Canadian Society of Clinical Neurophysiologists. His research has focused on neuroinflammation and improving long-term cognitive outcomes among children with refractory seizures and critical brain injury. He is also a member of the Canadian COVID Care Alliance. So for those of you who may have been following me since last fall, I've referenced the Canadian COVID Care Alliance a significant number of times. They've been a staple source of my information, and it's a group compiled of, a large amount of highly qualified medical science experts, such as Dr. Payne, who have helped me form my opinion and my decision making along with this in regards to the response to COVID-19. So please sit back and enjoy this incredible interview that I recorded with Dr. Payne. He gives an incredible amount of information, and really in a way that's very easy to understand. And he's up into some of the most recent information that even I haven't had the expertise or the time to really stay on top of. He lays it all out. It's very, very informative. Please enjoy. Thank you. Good afternoon, everyone. This is Daniel Bulford, former member of the Royal Canadian Mounties Mounted Police. I am currently the spokesperson for the group Mounties for Freedom. Today's date is Monday, June 6th, 2022. The time is 17:33 Eastern Standard Time, and I am here with the great Dr. Eric Payne. Dr. Payne, thank you so much for sitting down with me today for this interview. Most of the people that have been paying attention to let's call it the counter narrative throughout Canada and probably even internationally have heard of you and they know who you are. But for people who may just be starting to pay attention, and maybe they are even willing to listen to me because I am a former colleague of theirs or a friend of theirs, could you please just give me like a quick background as to your experience, why you became a vocal opposition to the mainstream narrative, and what you were seeing?
Yeah, sure. Thanks for having me. Appreciate all that you've done. It's great to meet you in Ottawa under those circumstances. But, nonetheless, thanks for all you're doing. I'm a pediatric neurologist. I have additional training in epilepsy and neurocritical care. I have a Master's of Public Health from Harvard University, so I have extra expertise in epidemiology and statistics. I'm an assistant clinical professor in pediatrics, and my research has been in neuroinflammation and in EEG monitoring as it pertains to kids with epilepsy that doesn't respond to medicine. My research has always been sort of clinically driven. I am also a father of 3 small kids. So when this sort of started, I came at this from the perspective of a physician facing a mandatory vaccine mandate from his employer in Alberta as a requirement to continue my job. And I could see that by the fall that our children were going to be exposed to these vaccines, and that inevitably they were likely be mandates that follow them as well as evidence. Right now, even still in the summer, my niece can't, participate in Girl Guides. Tim Hortons camps are requiring these vaccines for the teenagers. So that's all come true. The vocal opposition, I mean, it started really as a like a cry out for discussion. Like my letter, which is still available on the Justice Center, it was directed right to the members of the College of Physicians and Surgeons. Sent it to each of their inboxes. I also emailed it to the CEO at AHS at the time, Dr. Verna Yu. She forwarded it to her head science guy who responded to my email. The college themselves have never directly responded to that, but literally, as I said it, if I'm facing these mandates as a requirement to face my job, and the college was trying to decide whether or not they were going to make that as a mandate requirement for my license, so then you can't practice as a physician, period. I wanted, to see the evidence to change my mind on this. I mean, I'm a very reasonable person. I follow evidence, follow data. I love the detective work that's involved in being a neurologist. You follow the facts. Sometimes you're wrong, sometimes you're not. But at the time we were sitting there in September, there was every reason in the world to be asking those reasonable questions. And instead of having, the science laid out in a very straightforward way to say, you're misinterpreting this is wrong, what are you doing? That never occurred. And instead, what's happened is the same thing that's happened to a lot of people. There's been punishment and cancellation and losses of contract and research status. It's been an uprooting of your life. But what I have not seen is a coherent scientific rebuttal to the data. And frankly, over time, the position has got even more absurd. So, coming into the Omicron, which we can talk about, the data really flipped that narrative on its head. So, I came to it as a physician who has been pro-vaccine, who has vaccinated his own children with everything up until these vaccines, who has sat in front of, hundreds of families after their kids develop seizures after a vaccine, or they link autism, in a temporal relationship to a vaccine. And I've argued, about the, it brought out a tendency towards seizures that was already there. It wasn't the vaccine itself. It could have been an illness with a fever instead. I've supported these my whole career, and yet get deemed an anti-vaxxer based on an experimental genetic vaccine. And so that's been interesting. But also as a researcher who follows the data, and as a dad who's worried about these things long term in his kids. As a result of being involved, I've also subsequently, I've gotten involved with a really great group of people, the Canadian COVID Care Alliance. And I sit on their scientific and medical advisory board every week. There's over 30 of us, scientists from all different disciplines, clinicians, epidemiology, statisticians, people, COVID testing researchers, people working at labs testing COVID. We've got, people whose jobs it is to design vaccines, so vaccinologists and immunologists that are working with us. And we are extremely careful to review the science and to not overstate anything, and to try to sort of keep this narrative to something that involves choice, informed choice, but ultimately patient autonomy and choice. And so that's the background and how I sort of got involved with this stuff in the fall of 2021.
Okay, thank you very much. So your background, I mean, obviously you're very highly trained, a lot of scientific training, no doubt. Also, you mentioned you have a master's in public health. And so that would lead me to my next question. I know Lieutenant Colonel David Redmond brought to my attention some time ago about the various pandemic response plans that existed here in Canada prior to COVID even arriving on the scene. And admittedly, I've only read the Ontario plan and the Canadian federal plan. Now, I assume that Alberta has one as well, especially since Mr. Redmond himself worked in the Alberta Emergency Management Agency, or he ran it, I think, for a number of years. Have you seen that plan? the Alberta?
I've seen Lieutenant Colonel Redmond's document. He's circulated that, and I've read that, and it's very consistent with what you would expect to be a pandemic response. But his document goes further to offer solutions in terms of how we move forward.
Okay, so based on that, and with your background and your expertise, what have we seen overall from the COVID-19 response? I guess I'll put specifically to Alberta, and then maybe you could just expand a little bit on a national scale, like from the federal government.
So, from a public health perspective, one of the things, the first classes you pretty much you have to have to get your Master's of Science, your Master's of Public Health, is a course in socioeconomics determinants of health. So what are the factors that contribute to good health? And disease, COVID-19, is one of those factors, right? Other things like your ability to earn a living and put food on your table, things like, when it comes to parental health, how many daughters you have is actually very important for doing better than having sons. There's all sorts of things that actually turn out to matter when you look at these things, right? So the idea that this all or none phenomenon, where we were locking everybody down for a virus that we knew was selectively affecting the most vulnerable in our population, and not the young vulnerable, the older than 70, 80 years of age with 3 or 4 more comorbidities, the idea that we were going to blanket lock down even teenagers and young adults, to me, it was obvious that we were going to be creating an absolute catastrophe, that we were getting, the small business were going to shut down, mental illness was going to go up. For a lot of kids, school is an escape from bad homes, bad environments. We were shutting down hospitals, so we were going to end up with delays in sort of normal surveillance for cancers and chronic illnesses. It seemed to me that it was disproportional. What we typically do is we isolate, we protect the most vulnerable, and we did an awful job protecting our elderly in the homes. Like, it just horrendous. These people, my grandfather was in the home in Manitoba time. He was 101 years old, and he didn't die from COVID, but he stopped eating because he wasn't allowed visitors. That's how he spent the last 6 months. And that's a story that a lot of people died in isolation. I've heard that story not just from old people, but we did a terrible job protecting the most vulnerable, and yet we shut down the whole society and affected the whole society with these lockdowns. And so to me that seemed strange, and I was concerned. I could see some emails I sent even at that time. But right around that time, what emerged was a group of international experts. Martin Krusseldorf from Harvard, Dr. Bhattacharya, it was Stanford, and I'm forgetting the physician name at Oxford, the lady from Oxford. In any event, they authored the Great Barrington Declaration, which has over 50,000 scientists worldwide and physicians who have signed this, advocating for focused protections, exactly what we're talking about right now. And so it wasn't a conspiracy theory to discuss that at that time. It would have been normal policy to have those sort of accurate discussions, right? But they got slammed, and the interesting thing about Dr. Krusseldorf was that he was also a voting member, I think, on the VRBAC, which is the voting body for the FDA, and his whole career had been with pediatric vaccines. But after vocalizing his concern about this, he was removed as a voting member. But and there's an article, a peer-reviewed article that just came. I just got it sent to me last week. I have to go back and see when it was written. But over 50% of the people who vote on the FDA go on into lucrative jobs at these big pharma companies. So you only get to vote if you vote a certain way, and then you get rewarded for it afterwards. That's how the system is certainly created right now. So getting back to that focused protections, the other thing we found out through access to information, and through access to emails from the head of the NIH, the National Health Institute, Francis Collins, as well as to Dr. Fauci, who's the head of the NIAID, which is a subset of the NIH. they discussed the Great Barrington Declaration and the need to destroy the narrative before it emerged as a possibility. And so, the desire to keep us locked down and await this novel vaccine was there right from the get-go. And so that to me was, the thing at the beginning that really screamed sort of a red flag. The other thing, frankly, was the messaging with respect to children, where it was so clear that we were being scared out of our minds with respect to COVID. There was just no way around it. You were getting videos of people dropping in the streets of China. There was an active narrative that kids were going to infect their grandparents and kill them. We had evidence at that time. There's like over 12 studies before the vaccines showing that kids were not good at transmitting the virus to elderly people because they don't have the ACE2 receptors in their nasal pharynx the way other adults do. And the ACE2 receptor is like the key or the lock for the COVID or spike protein in the vaccine. The spike protein binds to the ACE2. So there was a physiological reason, and in addition to, over multiple months, lots of real world effectiveness data showing that kids, were not the sources of transmission the way that was initially said, including places like Sweden, where they didn't close their schools down and didn't mask their children. There weren't teachers dying or anything like that. Their kids are more likely to get it at home from adults. That was the one, crazy fear narrative. And still today, when you get asked about vaccines in children, and if you look at the information coming from the government, the authorities, with respect to illness severity, they say, yeah, kids can get very sick and die from COVID, right? And that is true. But they don't go on to quantify what that risk is. And that risk is a fraction of zero. Mm-hmm. So, your survival, and we knew this, before this thing had even come over to our shores, there were already data coming out of the Wuhan Children's Hospital, a provincial, that their local hospital that saw the sickest kids, that, it was not killing children. It was, the vulnerable kids were the ones at most risk, those with bad immune systems and other chronic illnesses. But, I don't even know that there's been a healthy child in the world who's been documented to die from COVID, even to date. And to put the number into more real terms, I mean, that, the overall survival is like 99.998 is what the number is for kids. We didn't have a single child up to age 19. So in the federal government likes to count 19-year-olds in the pediatric numbers for COVID. The first child who died with or from COVID was in October 2021. So that was a year and a half into the pandemic. That was before we started mass vaccinations in children. That was about 6 months after we got to 50% double dose in Alberta, 50% uptake on the double dose in Alberta, probably in June or July. And so this was October. And as we know, at least half of the deaths and at least half of the hospitalizations are not from COVID, they're with COVID. These are people that incidentally tested positive for COVID, or who did have COVID, were a little bit sick from it, but ultimately had something else that killed them. Mm-hmm. That's been acknowledged. And that first patient prompted a press conference by our chief medical officer at the time, who to let families know that ultimately we. Sorry, just getting yelled at by my wife upstairs.
I can hear that. That's fine. I'm used to it.
Yeah, I know, that's all right. She'll. So with the idea to let families know, this is the first child who had unfortunately passed away from COVID, and it was that child's, I think, sister who let people know the next day that this was a 14-year-old who had been end-stage cancer, mm-hmm. and it essentially died, with and not from COVID, and she had to publicly apologize for that the next day. So that just highlights, some of what misinformation, disinformation we were receiving. That was at a time where our government was pushing for vaccines in kids, right? So some more of that fear. Here's a child that's died of COVID right at a time where we want you guys to take the vaccine. The last time I checked the database in Alberta, we were up to 5 children since that time who've died with or from, and probably half of those were with and not from COVID, and all of them have had extensive, very bad medical conditions, right? So that's the reality of severe illness and disease with respect to children. And then you get the argument, okay, so what about transmission and a child's societal role, responsibility? Some people even argue, I would say that it is our responsibility as adults and as physicians to be acting as shields for our kids, not the other way around. But nonetheless, that's the argument that you hear. That argument is gone when you look at the real world effectiveness data of these vaccines, right? So, people, you have to see how these trials were made to sort of see, and then listen to the whistleblowers who talked about the fraud, listen to the editor of the British Medical Journal talking about the fraud in these trials. But essentially they measured, how many people tested positive for the disease over a 2-month span in the vaccine groups, 20,000 in each group, less than 200 people got it. The effectiveness data over time, if you look at just Alberta, for instance, and I mentioned Omicron was a game changer. Omicron came through Canada mid-December and sort of has stuck around. And right in Ontario and Alberta, and I sent you some of these figures. These are figures that were available on the publicly available website. So Alberta's publicly available COVID statistics, that figure was available until March 23rd when they took it down, even though that was the figure they were using and pointing to for a year prior. And Ontario still shows that data. And I've seen data from other provinces. That signal is there as well in British Columbia. It's there out east, it's there in Manitoba. But what it shows is, proportionally based on vaccine status. So not just what's the cumulative number, because it wasn't enough that, okay, there's more people who are getting COVID who are vaccinated. Then they started arguing, well, proportionally speaking, you guys make up a bigger group of the group. So it's not really, there's still some protection from being vaccinated. You're missing that because, 80% of the population is vaccinated. That was the argument. So I'm saying even taking that into account, proportionally speaking, taking that into account, the peak in Alberta with respect to Omicron was at least double, for the double fully vaccinated compared to the unvaccinated and the single vaccinated. And then as that curve came back down and leveled out, not quite to zero, but as it was leveling out, it was starting to rise again in March. And the top line was the triple vaccinated. All right, this is proportionally speaking. And it was at that time that they took the graph off the website. Okay, so that data existed with respect to proportionally, that there was maybe, if you don't want to give credence or credit to the fact that this suggests vaccine negative effectiveness, it certainly doesn't show you that the vaccine is effective at preventing transmission if proportionally the group that's the highest risk for getting COVID-19 Omicron is a triple vax. Yeah. And to that effect, I've listened to people arguing for confounders and how that affects testing. I didn't hear those people even acknowledging any of those confounders that could exist with respect to the testing when it was, the unvaxxed were disproportionately higher with respect to Delta. But that being said, more importantly, if you look at, the most recent Alberta data in the chart formation, where they show you a table formation rather, where they show you the number of hospitalizations with or from COVID, 60% are in the triple vaccinated, and the triple vaccinated only make up 38% of the people population in Alberta. They haven't been able to get past 40% uptake on the third shot since middle of January, probably because most of the people, or a large percentage of the people, at least know somebody that was fully vaccinated and got Omicron anyways. And so people are like, well, I took the shots and I got the disease anyways. I'm not going to rush to take a booster, which reflects the exact same spike protein in that vaccine, which was, apparently developed against the initial Wuhan spike protein, which hasn't been in circulation for over 2 years. It'd be like using 2 years ago influenza vaccine, flu vaccine, to try to treat this year's flu. Even though we've already shown that if you get 2 shots, you're more likely to get the disease. That's literally what we're standing at. So from the kids' perspective, in terms of transmission and serious illness, that data hasn't been there. And even Pfizer themselves, when they submitted their application to the FDA on October 26th, because serious illness and disease death is so rare with COVID-19, especially in kids, they had to model out. And, we all know how accurate these models are. but they had to model out death and disability. So they predicted that 1,000,000 shots in kids aged 5 to 11 would save maybe one child's life, is what they predicted. Pfizer did in their own modeling data submitted to the FDA with respect to the illness severity. And then on that same table, they looked at hospitalizations saved by the vaccine, and then they compared it to the hospitalizations and death induced by vaccine-induced myocarditis. Mm-hmm. So just the one side effect. They didn't look at any other sequelae, just myocarditis. They were comparing it head to head with how many deaths they saved by the vaccine. And they predicted that, on average, about 35 cases of myocarditis, excess myocarditis, as they called it, would lead to ICU hospitalization. And they predicted no deaths from those hospitalizations. And yet the data that exists right now with respect to myocarditis from previous, not COVID-related myocarditis or vaccine myocarditis, but if you had myocarditis from some virus in the past, the lowest death rate we were able to find in 5 or 6 different papers was 9% at 6 months. So you end up with scarring that never goes away, and some of these people do die afterwards. So this idea that you're going to get 35 kids excess in the ICU with myocarditis, based on, this is Pfizer's own data submitted to the FDA, and create 0 deaths, is I find that hard to believe and a bit optimistic. And if you get one death, well, now that one death offsets the one death you're saying was created by injecting 1,000,000 children with these things. And I mean, I guess to the point about the FDA, and their recent, because they just approved the booster in the 5 to 11-year-olds in the US. And that was based on follow-up data in their trials. They did not consider the real-world effectiveness data that's been published, including from New York State itself in January, showing that kids that were fully vaccinated had almost no protection with respect to transmission from Omicron. It was down to like 5 to 11% protection is what the overall number came. So we have real-world effectiveness data showing that this didn't work against Omicron, right? And yet we just approved this booster in kids, right? And so, the two arguments I make in terms of the disease severity and the transmission don't exist. Then we've got, and this is the thing to me that was the biggest kicker, even back in September when I wrote my letter, is the incredible black box that the long-term possibilities, side effects could exist with respect to these vaccines, right? Dr. Rubin, who was on the FDA voting committee for these in kids, said we're not going to know the long-term effects of these things until we start giving it to kids. Well, right, and that goes without saying. Of course, that's true, right? That's the whole reason why we have passive surveillance systems like VAERS and like VigiAccess that the WHO uses to sort of see if we can find a signal that would be concerning to pull these vaccines, because we're missing them in. If you only do a trial in 1,900 kids, which is what they did in the teenagers, and you've got a risk of myocarditis that is 1 in 3,500, you may miss that risk of myocarditis in that trial. But once you give it to 20,000 people, you might start seeing a signal, right? So that was always a concern. But we were told that we shouldn't be concerned because this was a vaccine, right? Keep in mind that the CDC changed the definition of a vaccine in September from providing immunity to providing protection, because these things in some of the real world data with respect to Delta had already dropped their real world effectiveness below 50%, like the Mayo Clinic Health Systems trial. So they had to change that definition. We were told that these things were not experimental by our governments, even though the phase 3 trials have still not been completed yet. We have the CEO from Pfizer himself being quoted a couple of weeks ago that this was counterintuitive, that these are, of course, experimental. They have never been used in this context ever before, even though the science, goes back to Dr. Malone and some of the patents in the early 90s. These have never been tried in the middle of a pandemic. We haven't used these as a vaccine before. And we were like, okay, so these are vaccine, but they're not really a vaccine. And we've never used genetic vaccine to trick your body into producing the spike protein. Usually we give you a piece of the protein or the virus itself. We make it so that it can't replicate, then we wait for the immune system to recognize it. Here, we were giving you an injection to make you pump out spike protein, which your body would then recognize and then form immunity to subsequent COVID exposures. It wasn't to the whole virus itself, just to the spike protein. So that was what we were told, and that injection would stay locally, and that the spike protein would just sort of present itself on the cell surface for a couple of days. Your system would come and recognize it, form an immune system, and it's gone, right? And my concern in September was that the biodistribution data, like where does this thing go after it's been injected? It was unbelievably absent. The only thing that we had at the time was through access to information, the Japanese Pfizer data that Dr. Bridle got, showing that in rats, this thing got everywhere.
Yes.
They didn't look at the brain in this particular study, but systemically, this got to the liver, it got to the reproductive organs, it got everywhere. And we also had at the time, we have a trial of healthy adult subjects in their, they're not elderly. These were healthy subjects at Harvard, injected with the Pfizer vaccines, and they had repetitive blood work done over the next few weeks. And it measured that the spike protein was circulating in those bodies. This is published in peer-reviewed data.
Is that healthcare workers?
This was healthcare workers in Boston, as far as I'm aware. That's right. It was only a small number of them, like 13 in this study.
That's
and
right.
They showed that the spike protein was circulating for days and weeks, and some of them at different concentrations. We don't know, meaningful concentrations, whatever. But the narrative that this was gone and tethered to a wall and didn't circulate was not there based on those studies at that time. Since that time, we have the studies. We have 2 papers on Moderna and in Pfizer from Australia, when these companies were looking for approval by the Australian authorities. You can find in the middle of their 50-page documents, I can send you these things, a table where they show the biodistribution data. And it showed in these animals that it got into the brain as well as the body. So it does absolutely circulate. And to that effect, there's a case report just I saw last week where an adult got the vaccine and developed prolonged seizures after the vaccine, and they were able to measure spike protein from the vaccine in his spinal fluid. Okay, so that is in the literature. It's like, it's not misinformation. We have found spike protein post-vaccine in somebody having long seizures, right? And these things are like, I think overall, these acute injuries, represent, a fraction of a percent. But when your risk is a fraction of a percent, these things start to become quite meaningful, right? Serious adverse events in the trials themselves was guess at like 0.1 to 0.2, not guess, was measured in those things. So we know this thing can travel everywhere. We now have studies where the lymph nodes are still pumping this spike protein out 3 to 4 months later. We have studies post-COVID and post-vaccine showing that the spike protein is still circulating in the blood even 12 months later, okay? We've got evidence that's emerged that spike protein can interact with tumor suppressor genes, including P53 and the breast cancer gene, BRCA. P53 is important for our DNA to sort of recognize when there's mistakes there so that they don't get amplified and develop into cancers. So the spike protein has been shown in vitro models to bind these things. We were told that this thing can never get into your nucleus, the cell nucleus. In our cell nucleus is the control center for our bodies. It is where we inherited our genetics from mom and dad. It is, where ongoing proteins and, those type of synthesis things happen. We were told that the spike protein gets made in the cell cytoplasm by ribosomes, not inside the cell nucleus, because the idea is if it can get inside your cell nucleus and it can integrate inside your cell nucleus, and then all of a sudden your body has a genetic sequence to produce spike protein. And so now spike protein is not foreign to your body. And when you do get spike protein, you do get coronavirus in society, you could be in a lot of trouble, right? And we were like, this can never happen. This doesn't happen. Well, a paper about a month ago, looking at an in vitro cell model called HUH7, which is a cancer liver cell model, showed that there was upregulation of a certain protein called line 1, which makes, so usually you go DNA, mRNA to protein. This made mRNA to go to protein to DNA. So it was a reverse transcriptase that was upregulated when this cell model was exposed to the Pfizer vaccine. And they were able to show that the spike protein got inside the nucleus. So The idea that it can't happen and that this has been debunked and that you shouldn't worry about it is not consistent with what we've learned the last few months. And those concerns from September with respect to those transmission things have only been amplified at this time. So given those three main points, I don't understand why we cannot have a real accurate conversation about giving these things to kids. Other countries in Scandinavia, Denmark, have pulled these vaccines among healthy people, not just children, 30 and under.
30 and under, that's right. Yeah.
Right. This is not a conspiracy theory. This is other countries looking at the data saying, we're not going to force this anymore. Right. And the final point, and I'll let you ask a question, but inevitably the argument becomes, well, there is still some benefit with respect to serious illness and death. Okay. And, with respect to kids, I've already sort of touched on how rare that is anyways. But we have data because the UK is about, 2 or 3 months ahead of us on the vaccine schedule. And their publicly available data that I went through early March showed that 9 out of 10 deaths with or from COVID occurred in those who had been vaccinated. And they have less than 8% uptake on the vaccine. So that was the data there. The data in April from the UK showed that the triple vax occupied more deaths than all other vaccine statuses put together. Okay. When I wrote my letter to the college in September, I was able to cite a paper that was in Science in September showing that 60% of the ICU admissions in Israel, who were about 3 months ahead of us on the vaccine schedule and who were already on to their third shot at the time with Delta, 60% were in the vaccinated, right? So this data has been there for many, many months. And now there are concerns about things like antibody-dependent enhancement and some of these things that a lot of very smart people talked about year and a half ago. We're now getting evidence that that's happening. And instead of having a discussion about this, these facts are being taken off the website, and anybody who's talking about them are being censored even more harshly.
Well, you covered a lot there. And I think two of my main questions specific to your specialty were going to be about risk to children from the actual disease versus risk to children from the vaccines, which, I mean, that I already had a strong idea as to how you were going to answer, but I think it's would I be accurate in saying that more risk to a healthy child, there's more risk, more potential risk from the vaccine than there is from the actual virus?
From my perspective, and I would welcome a discussion with anybody. Love to have a discussion with any of the experts currently arguing the contrary. There is no question in my mind that these vaccines are going to cause more harm than good in kids. There is no doubt. That data already exists, in my opinion. That is independent of whether or not people develop chronic inflammatory issues or cancers long-term as a result of repeated injections, which we have. We don't have 6-month long-term data on the third booster yet. We don't have, we don't even have accurate 1-year data on the first series of shots. The Canadian COVID Care Alliance video that was entitled More Harm Than Good.
Yep.
Right?
Yep.
That data, that's important for people to hear this. That data was Pfizer's own trial. 6-month data trial, because as I mentioned before, the trial actually looked at efficacy and safety only up into 2 months. Okay. So this was their 6-month follow-up in the adults, in the 40,000 that were done. Okay. They tried to get that data hidden. We had the people, docs went to court to get that data exposed. First of all, which should tell you everything you need to know. Because if all these doctors are yelling nonsense and these things are as safe and as effective as you say, show us the 6-month data. Shut us up. Debate us. Make me look like an idiot. I will stop talking these things. I will reverse it, whatever. But when you go to court to try to hide this stuff, you can have a bit of a spidey sense that something is not quite right, right? And so what did that 6-month data? Well, at 6 months, there were 6 more deaths in the group that received the shot than in the placebo group. Right. Yep. There and those patients, some of them died. I think some of them actually may have died from COVID, and there were also clots, heart attacks in that group. I'm not saying that they died from the vaccine. All I'm saying is, don't tell me that there's any evidence in phase 1, 2, 3 trial data showing that these diseases prevent injury and death when there were more deaths in the vaccine arm at 6 months.
Well,
and so if we can show that in healthy adults, right, then, you know, it's certainly going to be the case with respect to kids.
Yeah. And I think this is important for people to know if they're just starting to look into things for themselves like that. I think initially they tried to have that information protected for 55 years. Is that correct? And then they were overruled. And then when they appealed, they tried to go for 75 years. Is that the way it went? I think it went 55.
You're talking about a different set of data.
Okay.
But this is you're right. There's 2 occasions now where Pfizer's tried to hide the data. The first was the 6-month data.
Okay.
What you're describing, and you're describing was the FDA itself. The FDA itself
Yes.
went to the court to try to prevent the release of the data that Pfizer had provided them in order for them to grant approval for these experimental vaccines that remained under emergency use, experimental emergency use authorization at the time. And you're right, it went 55, then 75 years. And we have now had release of a lot of that Pfizer data, right? And to the same logic, you're going to hide if it does, if it's in your favor, you're not going to hide it. What we found in the first Pfizer dump, and I spoke with Dr. Panesi about this on one of her podcasts after the first Pfizer dump, but there's been 2 more bigger ones since that time. But we already knew that Pfizer had received 1,223 reports of death associated with the vaccine. It doesn't mean it was because of the vaccine, but it was associated temporally with the vaccine. And they were missing data with respect to those 1,200 patients. Even they hadn't even done their due diligence on those numbers. There were something like 40,000 adverse events that they had heard about in the first 3 months of rollout. So this is like November, December 2021 going in, like 2020 going into 2021, before we even had these vaccines in Canada.
Right.
They were already getting this massive signal of adverse events. And the other things that we've learned since that time, and some of these things we knew already, like the fact that, the original trials, pregnant women have never been included in these trials. If you look at the original drug monograms for Pfizer and Moderna, which I have, and I can send you, they explicitly said that, pregnant women were excluded from those trials, right? And this is in the context of the biodistribution data, as we've just talked about.
Yeah.
And so the other things we learned is that the FDA Pfizer definitely recognized the fact that natural acquired immunity was a thing with respect to COVID, and that that was relevant. We found out that they had to hire thousands of more employees in order to actually catalog all the adverse that they were having. So that's what they were getting, and that's why they tried to hide that. Why the FDA tried to hide that. But I think, importantly, what we have other surveillance systems, right? And that's never going to be as good as a patient in a trial who's being monitored by the trial to see if they've got, actively monitored to see if you've got side effects. This is passive surveillance where you're requiring a physician or the patient themselves to report their own symptoms, right? And that was what was reported to Pfizer in their data. The VAERS system, the Vaccine Adverse Event Reporting System by the FDA and the CDC, that allows reports by physicians and patients, and it's international, but 80% of it is just US. And then you've got the VIGI Access database, which is what the World Health Organization uses to surveil these vaccines. And these are publicly available data. And I think I sent you some of these figures. To me, that to put this in perspective, the idea of these systems, they don't prove causality. They're there as a post-marketing signal surveillance. In the past, the VAERS system has been used after 15 cases of intussusception, which is like a bowel telescoping on itself. They pulled the rotavirus vaccine after 15 of these incidences, right? So it's been used for that in the past. And what we have in the VAERS database and the VIGI-Access database, if you look at all vaccines since 1970 in the adverse reporting system, it does this line like this across time. And then COVID vaccines come along and it hockey sticks up like this. And you can do this yourself, figure this out yourself with this data. All vaccines put together since 1970, all adverse reports for all vaccines put together since 1970 are less than the adverse events currently reported with respect to COVID-19.
In just over a year.
In just over a year. So the VIGI-Access database, 3.5 million adverse events reported in their database. A third of those are neurologic. And if you compare it to all other vaccines or the standard vaccines that we use in kids, and you put this in the system, you ended up with less than 1 million reports of all other vaccines combined in the 40 years versus 3.5 million with respect to this vaccine itself. Now tell me that's not a signal, you know. And the VAERS database right now has got about 30,000 deaths in it, right? And we also know that the VAERS database and all passive surveillance databases underrepresent the actual number of cases. So there's a study, there's a Harvard study that happened before COVID where it looked at the VAERS database to see how many adverse events were being picked up. And it found 1% to 10% only were being put in VAERS. So VAERS always underestimates the numbers. There are a couple of Department of Defense whistleblowers who have testified in front of Senator Johnson, who have argued with data that the underrepresenting number with respect to deaths in the US is 10. So there's 30,000 reports in the system. He's suggesting that based on the Department of Defense whistleblowers who have access to a different database, that number is underrepresented, actually 300,000 more likely in the US. So those are the kind of numbers, but we can't even have an accurate discussion. You know, there's something like 200 or 300 kids in the database who have died post-vaccine, and the CDC has not allowed an independent investigation into those cases. So there is a screaming signal. That signal, interestingly, is not really there in the Canadian database, and there's reasons why I think it's there. I think it's awful that it's not there, but there's reasons for it. But the other big databases, the VAERS, CDC, the UK yellow card system, the VIGI-Access, the Euro surveillance system, these are all showing you that there's a signal there.
I mean, I've even myself personally, I've visited all of those databases trying to corroborate that information for myself. I did have some success with that, and then I know I've heard the exact same message from both Dr. Jessica Rose and from Dr. Peter McCullough, like exactly what you just said, that all other vaccines combined over 30 years have less adverse events and death associated than just COVID vaccines in just over 1 year. And so
yeah, I sent you the figures for VAERS and for the VIGI-Access. So you can pop those things up at some point. But yeah, it's remarkable.
And like you said, it's exactly like that, like a hockey stick on the graph, right? So I guess that would lead to my next question, in that people may hear all of this information, and even if they believe the numbers, I think it's very easy sometimes for people to just look at the statistics as just numbers. I mean, not forming that connection in their mind that that's a real person, right? That's a real person who's been involved, who's been, impacted, potentially died, and so their family has been impacted. I don't know if you're allowed to answer this or not, but have you seen any firsthand evidence of harm from these products?
Yes.
Okay.
Yeah, absolutely. And I've seen I've had dozens of patients, hundreds of patients reach out to me, either in person or via email to explain their cases. I haven't necessarily examined all these people to say, but the temporal relationship, the interesting thing about the VAERS and the VIGI-Access when this gets looked at is that the majority of these side effects that are being found or within 2 days of the vaccine. You get someone who's otherwise totally healthy, you take the shot, 2 days later, you're paralyzed. Like, come on, what else is it, right? So those are the kind of things that we're sort of seeing. If to your point about losing people, the narrative in statistics, right? It's extremely important. And if you're trying to find out, wrap your head around this a little bit, I would recommend that you Google a patient by the name of Maddie DeGaray. Last name is D-E, last name is G-A-R-A-Y. And she's a teenager who was in the Pfizer trial for the 12 to 17-year-olds. And the first author on the New England Journal of Medicine was her PI in the States. And she got removed from the trial and coded as an abdominal side effect. She's testified, and you can find her testimony, her mom's testimony. You can decide for yourself. She's been left with paralysis. She ended up with a transverse myelitis, and as a result is wheelchair bound and getting fed by a tube. And so that's a real person who's been affected by that. By what looks to be that vaccine. There are other cases as well. I mean, for instance, there's a case I'm aware of in Ontario where this healthy young adult, I think he was like 21 at the time, took the vaccine so we could play hockey in the fall, even though him and his dad had sort of decided that we're going to wait it out. But teenagers have been by far the hardest hit with this. Their lives have been uprooted. I mean, it's been devastating what we've done to teenagers. So we took the shot so we could participate in society, and he died of a heart attack, right? And so this is being investigated and is being looked at. But the dad tried to just sort of get that story out, and he was censored on Facebook and all these platforms. So family members who are trying to get the story out about their own loved ones are being censored. And so there are other projects of the vaccine injured. You can Google these things. I mean, there's hundreds of these things. There's dozens of videos highlighting the individual lives that have been devastated. I know colleagues in medicine who have had side effects from these vaccines, including permanent ringing in the ear, or watched family members be affected by the vaccines themselves. But there, for some people, there's a self-fulfilling prophecy whereby these vaccines are super uber safe and effective, and they can never cause harm, and so they never cause harm. But there's another group who are very well aware that these things are happening and are seeing them and are not speaking out about them, and are worried about losing their license or whatever if they do. And a lot of that, I think, there's different reasons for it, but you don't want to admit to yourself that you've taken an experimental vaccine that's caused harm. But the reality is you never received informed consent. So, you were never making these decisions based on all the data that we had at the time, because all the truths were being hidden or misconstrued. I think that list of injuries, I mean, I think that, the last point I think is very important, and it's the all-cause mortality data, right? And so it shows this is excess death in the world in different countries based on statistical norms. And these are very, very stable statistical norms that don't change at all. And the insurance companies and other researchers have been showing that in 2021, not 2020, the first year of the pandemic, but 2021, after the vaccines had been induced, after the lockdowns had been induced, after all the measures had been induced to fight this vaccine, that all-cause mortality has been increasing. And it was as high as 40% increase, which, according to this Indianapolis insurance company CEO, this was a 1 in 200 year catastrophic event if it was 10% increased, right? And then there was a German insurance CEO that came out and mentioned this data, and he got fired within 3 days of pointing to this data. But this data is there in multiple data sets. It's impossible to hide that fact. Edward Dowd, who was a former Wall Street guy and worked for BlackRock.
Yeah.
He's been pointing to this excess mortality as well. So, I'm not saying it's all vaccine related, but it's certainly all related to our actions in 2020.
to the
right?
overall response.
That's right. We haven't had more deaths in 2021 that COVID related than we did in 2020. We didn't have the vaccine in 2020. We did not see a spike the way we're seeing. And the problem is that number is still going up. It's not going down. So, why are we still seeing excess deaths? And the concerning part in my mind about that is that it seems to be disproportionately affecting our young, healthy people. Young, healthy males in particular are the ones that are being affected. And their risk from coronavirus itself was a fraction of zero. I mean, it's a reason why Denmark and Japan and Sweden have removed these vaccines for 30 and under year olds, right? Because they have deemed that the risk doesn't outweigh the benefit.
Yeah, because I thought when I was reading about that Indianapolis insurance CEO, I think he was specifically mentioning in the 18 to 44 year age range, right? So like pretty much your prime working years. Yes. Almost. Yeah.
That's right.
Okay.
Yeah.
So I guess specific to your experience in neurology, you touched on something a few minutes ago earlier in the conversation about a lot of the potential injuries being neurological in nature. And I've heard other people, like in the medical science community, talking about how the spike can cross the blood-brain barrier. Can you speak to that with your specific expertise?
So, what we have for evidence for that are some of the things that I mentioned already. We've got the 2 animal studies that were submitted to the Australian officials, one for Moderna, one for Pfizer, showing that it distributed throughout the brain. And then we've got that case report that I just mentioned where, somebody got the vaccine and developed prolonged seizures and they measured a spike in his spinal fluid after that case. Okay. The idea is that we've got something called a blood-brain barrier that prevents things from getting into our brain. You can get in through different ways, but most things can't get in. And certainly our traditional vaccines would have no reason ever to get into your brain. They would have no reason to sort of, circulate around and develop the way that these things are. But these current ones, if you think about the Moderna and the Pfizer, that contains the genetic material, the mRNA for the original spike protein, or closely they're related, is housed in a fat ball, a lipid nanoparticle. And our bodies don't tend to recognize fat balls as foreign, right? And so it's not surprising that, if this thing is not tethered to the wall the way they said and can circulate, that it would go undetected by the immune system. And one of the things that can pass blood-brain barriers are things, because the blood-brain barrier is made up of fat, of lipid, and things that are lipid loving, can pass those things. So it's not a shock when you see that these things are flying around in the body that it could get into the brain. And that was something, that was certainly seemed pretty obvious to me as a possibility back in the fall. If you look at the AstraZeneca and the J&J, they used a chimpanzee adenovirus. So a virus that humans don't tend to see. And they took outside, they removed its ability to replicate inside the virus, and they put the DNA of the spike protein inside those. Those adenoviruses are very well known to be able to to go everywhere in the body. They're used. One of the areas of possible use that could be very beneficial is as a genetic vector. So certain diseases have got a gene that's caused the disease, or cancer therapy. We can't get it into the brain necessarily, so something we give it right into the spinal fluid. But these type of vectors, whether it's a chimpanzee adenovirus or a fat ball, are used to transmit either medicine or genes in other places. So not surprising. But normally, if you get a virus right in your body, that virus shouldn't be able to just shouldn't be able to pass your blood-brain barrier and infect itself, right? I mean, that's meningitis, that's encephalitis. We get lots of viruses that never infect our brain. so it's an effective housing system. It can for sure be leaking. You can get infections in the brain here. But what the suggestion is not so much that the adenovirus or even that the nanoparticle fat ball itself is getting into the brain. It's that that the spike protein, once it's created, could possibly do that. And there are certain areas of the brain that we know are more have higher representation of ACE2, which is the lock that binds the spike protein, allows it to sort of do what it's doing. And that includes the basal ganglia, which is in the middle of the brain, helps coordinate movements. And there's been all sorts of sequelae, possible side effects from the vaccine and from COVID. I mean, these things are described in both. And that includes, not just the clotting and the bleeding that we've heard about a lot. That's why the AstraZeneca was pulled, the J&J, with respect to clotting and bleeding. We know that it can cause inflammation of the nerves, right? So the first payouts in Canada, based on a CBC article this week,
the guy in BC.
To a guy about our age who developed Guillain-Barré, which is inflammation of your peripheral nerves. It presents as an ascending paralysis, and it can be life-threatening if it starts to affect your breathing nerves. That has been something we've seen with other vaccines in the past, and it has been a reason to take vaccines off the market in the past. But as I mentioned with the Maddie DeGarre story, she had inflammation of her spinal cord. And so this is peripheral nerve, and we've got central nerve inflammation. That's a possibility. We've got clots that are a possibility. And we've got other things as well. I mean, the list is pretty remarkable. We know that the eyes, for instance, are a place where this looks like it can biodistribute. And there are things like retinal detachments and other things that are described in the VAERS reports, people getting blind after these vaccines in very rare circumstances. And unfortunately, 2 years out, instead of data to say, okay, we've looked at this and this is not the case, we have no counter argument that makes any sense with respect to these numbers, right? It's just pulling these numbers away, hiding these numbers, going to court to prevent the release. And so it's hard, it's impossible to imagine that this signal isn't real to a large extent. I mean, I really do believe that, not only did a lot of people get Omicron who were fully vaxxed, and that's why they're not getting the shot, but a lot of people are know people who have had side effects from these shots now. They have themselves developed, side effects possibly. And so there is concern there, right?
Mm-hmm. Well, I think, and a lot of the different conditions post-vaccine that you've mentioned, if people haven't already, they can go right on Public Health Canada's website, and you'll have to navigate your way through a number of fields because, like most government websites, they're not super user-friendly. But ultimately, if you find your way to the COVID vaccine safety, you keep following the links and you'll find adverse events of special interest. All of those, even Public Health Canada recognizes that there's, I don't even remember the exact number, but probably overall, like well over into the thousands of reported side effects, cardiac or neurological, and like you said, transverse myelitis, Guillain-Barré syndrome, lots of different cardiac events, all even recognized by Public Health Canada. And like you said, likely very underreported. And so that would lead to my next question. So my brother has given me permission to share his story, but he is a RCMP officer as well in British Columbia. After his second dose of Pfizer, he suffered 3 weeks of intense stabbing chest pain. He spoke to me about it. He knew my stance, and I really, really pushed him to go see his doctor about it. His doctor kind of told him, it'll probably just resolve itself. You'll probably be okay. And he never received an official diagnosis. Afterwards, after I made a number of connections with different people, like through the COVID Care Alliance, after I started speaking out, I was able to get him linked in with another doctor who's fully aware of the risk and is willing to help him. But that's the story I've heard over and over and over again, is like you mentioned, hearing hundreds of stories from different patients. If I go to a large public event and people recognize me, I quite often get in the dozens for certain other people coming up to me in confidence saying like, I'm a federal employee. I didn't want to take it. I took it to keep my job, and now I'm having cardiac problems. And some even like they had a serious adverse event cardiac wise after their first dose, and they're still not even allowed to get an exemption from their second. What's your perspective on why is that the case? Why is there such a reluctance for people to acknowledge, for physicians to acknowledge that people have been injured by these products, and why so few of them probably do end up being reported? Like, I think I did hear that in order to get to that Public Health Canada website table that I was talking about, I've been told that you have to it has to go through roughly like 5 layers of bureaucracy. And that's even if people are willing to actually advance it to the next stage in order for it to be recorded. So why the reluctance?
So that's a great question. There's so much to say on that. I'll start maybe answering so first of all, your brother's story is definitely not unique. And what's also not unique about it is that has a hard time, being taken seriously by his physician. I have a lot of people reach out to me just saying, I just want to be taken seriously and not discriminated against as a result of my vaccine status. Or I took the shot. I did what you told me to, and now I've got these injuries and you're not recognizing them. I've seen cases where we've sent kids to an allergist because they've had a previous allergy to a vaccine, trying to get them a vaccine exemption letter for these things. And the allergist says, yeah, he should get a vaccine exemption letter, but doesn't want to write the vaccine exemption letter because he's worried the college is going to come after him. Mm-hmm. So there's a part of it, I think, is, that self-fulfilling prophecy where these things are safe and effective. And I've been telling everybody they're safe and effective. And I'm so convinced of it that I've injected my 6-month-old. And so how are you going to see that, that's sort of that mass formation stuff that Christian Desmond is talking about, that cognitive dissonance where, the free floating anxiety is resolved by a sense that government is there to help you and that these vaccines are going to make everybody back, safe and effective, and it's going to go back to normal. And if all of a sudden that proves not to be true, well, my ability to stay happy inside gets affected. I think that's part of it. The reality was a lot of these side effects we're not aware of at the time they were brought out, which is why a lot of us were saying, well, let's hold off on giving these things to like pregnant women and to kids. If you look at just what we've learned, like since September, when I wrote my letter, AstraZeneca was pulled because of a brand new disease. We never vaccine, VITT, VIT, I'm going to mess up thrombo. It's vaccine-induced thrombotic thrombophilia or something along those lines. But it's a bleeding as a result of the AstraZeneca. The J&J just 2 weeks ago, it's clots. We are all aware of the myocarditis risks, and the Moderna in particular, because it's 3 times the dose of the Pfizer, seem to be more at risk for doing that in kids. And so Health Canada removed, recommended Pfizer over Moderna. This is a moving target, right? And so some of those vaccine injuries, we've only recognized with time. So that's part of it. And with respect to your specifics with the Canadian database, right? So you're right. One, there's a lot of docs who don't think that this is a possibility. So a lot of docs don't even know that vaccine system exists in Canada. It takes about an hour to put in a vaccine adverse report into that system. Which is 2 or 3 times longer than it takes to put in on the VAERS system. So it's much more involved. It can only come from a physician. So the VAERS, about 20 or 30% of the reports are coming directly from patients. Yeah. So that's one reason why you're missing them. The reason that upsets me the most that you're missing them is because there's a bureaucrat on the other side who's denying the vaccine exemptions. And I say that with possession of a letter from those bureaucrats stating that one of the patients on whom a vaccine event report was filed by a GP who had examined the patient and deemed that they met all 4 criteria to be, in terms of the time, no other explanation, and so forth. And they're sending out letters to these physicians saying, we've decided that that wasn't related to the vaccine, and as a result, we're taking the patient out of the database. So that is happening because I've seen those papers. And they're not doing that after talking to the patient or examining that patient themselves. They're just punting that out of the system.
Like a unilateral decision.
I don't know who's making the decision. It's a templated letter that comes plaque stating that these are the criteria for a vaccine associated event, and we've deemed that your patient does not meet that criteria. As a result, we're removing them from the database. And I've had, some of those physicians have written back saying, what do you mean? On what grounds are you denying this? Right? And then it goes unresponded to. So in Canada, I can say with 100% certainty that some of those things that even when a doctor puts the time into putting in those adverse events, believes the patient, puts the time into it, there is still a mechanism in place in Health Canada somewhere, I don't know who's doing it, where these things are being punted out and denied.
Or beyond the bureaucratic obstacle that you just mentioned, do you know what the step-by-step process would be in order to go from patient, physician, and then that would have to go to a health services, I imagine probably provincial level first, how it would eventually get onto the federal
so
recorded federally?
It's a federal database. So
Yeah.
you log into it and they would be capturing these on a federal level. Yeah, as far as I can tell.
So would not be filtered through Alberta Health Services then.
It's not getting filtered through AHS as far as I can tell. I don't know the filtering system of where that goes. I honestly don't. But I don't know who's making that decision. I just know that is happening based on a letter. But I don't have, in terms of why on these individual bases. I mean, the whole idea with these databases is to collect the data, right? And you can always go back after the fact to go in and look at these things. I mean, did they go back and get rid of all the deaths that were with and not from COVID out of their database? They haven't done that.
No.
The national database still includes both.
Still saying roughly 40,000.
That's right. So they're they're still including still using a public number that we know is inflated by double by their own admission. And yet they're scrubbing possible side effects out of their database. So that's the problem. And then ultimately that go back to the fear. I mean, there is real. I mean, one of the Ontario physicians recently who got sanctioned by his college, for a number of things, but one of them was because he was writing lots of not vaccine exemption letters. He was writing vaccine reports, vaccine injury reports. It was deemed unprofessional that he was recognizing so many of these injuries, right?
Yeah.
I mean, I have had the college go into my records looking for vaccine exemption letters because we're not allowed to prescribe vaccine exemption letters. They tell us unless you've had a near-death experience with the first mRNA vaccine. What they also say on their website is that in rare circumstances, in the right context and in the right discussion with the family, you can write rare vaccine exemption letters for your patients. And there's a form you've got to fill out and you've got to document it very carefully. So one of the college complaints that I've received was that I was writing vaccine exemption letters. And I wrote vaccine exemption letters for a few patients, rare patients. I think the college found 8 patients in 100 files that they went through. These were all patients I've been following for a long time. There was one kid who'd been getting vaccine exemption letters for like 10 years. Other kids who had inflammation in their brain and refractory epilepsy, who were trying in some instances new inflammatory meds. So these were informed decisions by the family to hold off and wait and see. So we were allowed to grant these for a certain period of time, and generally I granted them for one year. And that complaint was closed because it was deemed that those exemption letters had been well documented and they were justified, right? But the majority of physicians don't realize that that's the case, that there are, rare exemptions, rare instances where it's reasonable to do that. And, you may or may not get investigated by the college over that, but if it's a patient, and it's well documented, those things can happen. But that speaks to, it's another one of those weird things that doesn't make sense.
Hunting physicians?
Well, hunting physicians doesn't make any sense, but the idea that you would step in between a doctor and a mom and a dad to decide what vaccines their kid's going to get. Like, you've never told me I couldn't write vaccine exemption letters, and we write rare exemption letters. There are definitely reasons to do those things, rarely over time. And as I mentioned before, I've advocated for vaccines in front of hundreds of families. But I still have written vaccine exemption letters for some patients in rare circumstances. But with respect to COVID, we were told that it was unprofessional to do that, with the vaccine that had been brought to market in 3 to 6 months in the middle of a pandemic, with, as the one of the head voting members of the FDA said himself, we're not going to know what happens with these things until after they've been given, right? Mm-hmm. So, that's the reality that I've been facing, try to wrap your head around that. Why is it that all of a sudden we're forcing people, like you alluded to, someone who's had heart inflammation after the first shot, why are we forcing them to take the second shot? Especially if they've already had the virus, right? Mm-hmm. If they've already had, not recognizing natural acquired immunity, which they all seem to recognize now. Even Fauci and the CDC, Pfizer, they all are recognizing that at this point. But at that point, even with evidence to say that the people who were highest risk for myocarditis were the ones who had received a full series of the vaccine first and then got the virus out, or had the virus first and then got the vaccine, right? We knew that they were at increased risk. So there was always reason to offer an exemption to someone who just had the disease, especially if they could prove immunity, which, we've got testing to be able to do that, right? So that part hasn't made sense. And I mean, frankly, you and I heard last week, we've got a prime minister who's still not letting the unvaccinated fly or get onto trains in this country. We can't leave our country to go to the U.S., despite the fact that the data, as I showed you, the publicly available data, show that it's the vaccine, those who've had the triple vax, that are most likely to have it right now. It's certainly, we've had data back since July 2021 that this didn't prevent transmission in Israel. In August, the CDC director said this doesn't prevent transmission. By September, we had multiple studies showing that your viral load was the same regardless of your vaccine status. We have known about the transmission aspect of this with respect to your vaccine status for months and months and months. And now it's flipped to the point where the vaccines seem like they may actually be in certain circumstances more at risk, and yet completely discriminatory, completely unscientific. And that's still going on, even though, the rest of the world has recognized that that's the case. But we are still now, fighting this stuff, despite the data that you can find in their own public available databases.
Well, that's something I've said to people in many conversations. Like, the messaging that you hear come out of their mouth on camera does not even match their own data that they have publicly available on their own website. And I always reference the Ontario website because that's where most of these conversations take place. But knowing all of the things. Oh, and just one thing I'd like to add to your point that you just rattled off there, back in July of 2021, knowing that this didn't prevent transmission. Did you know even Prime Minister Trudeau admitted that on camera?
Oh, did he? I didn't.
Yeah, he was at a press conference in Moncton, New Brunswick. I think it was a infrastructure announcement, possibly. But in that press conference, Prime Minister Trudeau, out of his own mouth, said that even if you're double vaccinated, you can still get and transmit the virus. And then he kind of caught himself and followed up by saying, well, but it's just more difficult. And that was around the same time I was already hearing from other experts that it looked as though Delta was already able to escape the immunity from the vaccine.
That's right.
And that was right, like leading up to the big Delta wave in the fall, early fall.
Yeah, I mean, the reality, if you just one very quick point onto that effect, when you look at the data and any of the studies that they say support effectiveness, right, or efficacy even, there's either a problem with how long they followed patients. So the original trials only looked for 2 months. That's often the main issue, or they do what they're doing in the pediatrics, which is not even positive cases. It's using an immunoreaction. They're seeing whether or not kids can generate antibodies or react to being exposed to the vaccine. So they call it immunoreactivity. That's what they're basing the effectiveness of these vaccines in kids, because they can't show that outside of it, right? We know, if you look at across, that there does seem to be time-dependent improvement with respect to some protection from transmission. And that goes from about 2 weeks after the vaccine. They're actually more at risk of getting COVID in the first 2 weeks of the vaccine. That's also on publicly available Alberta data that was taken down. I can send you that picture. But you're protected from about 2 weeks post-vaccine to about 2 months. And then it rapidly falls off from the transmission perspective, right? That's probably about as accurate and honest as you can be with respect to the transmission. But what we've seen now going into the Omicron is now that you're more likely to get it with respect to being triple vaccinated. So there's something else happening now.
Well, and you just said that for those first 2 weeks after, you're more susceptible to COVID infection. And yet on the government database, you're not considered vaccinated until after that 2 week time. So you could be one of those unvaccinated or partially vaccinated COVID cases that's recorded in the database, even though you've already taken the injection, but you fall within that 14-day time period.
That's right. That's
right. And I think in BC it's 3 weeks. Is it 21 days? 3? I think
most
in British
places,
Columbia,
the UK and most places it's 2 weeks.
Yeah.
And so that's right. If you died anywhere until 2 weeks after your second shot, you were not considered vaccinated. And then we've got this evidence to suggest that there was a small peak after getting vaccinated. And keep in mind, I mean, that main push in the fall against Delta, when we were pushing the vaccines, we were also being exposed to an enormous amount of virus in the community. I mean, the push to vaccinate was happening at the time that the virus was hitting our population. That was that fall push with jobs when the Delta was coming, right? So all those patients who got Delta, unless they had gone through that series, before, a lot of them some of them had started the train, right? My point is they'd had one shot, or they, not quite got there. So that accounting piece, I've always found interesting. And the other, to that point, the Alberta data, if you go to the Alberta statistics and you go to vaccine outcomes, which is one of the main tabs there, until recently, the first paragraph was like 6 bullet points. And the last bullet point was the number of people who have died in Alberta died in Alberta due to COVID-19 or from COVID, with or from COVID-19, who were unvaccinated, all right? And that number in the fall, they were showing that 80%, like when I wrote my later, 80% of the people dying from COVID in the fall were the unvaccinated, based on that bullet point on their website. The tricky part about that bullet was that the clock started January 1st, 2021. So they started counting deaths in January, which was 6 months before half of our population were vaccinated. So every death that happened in January until June happened before the vaccines were there, but they added that to the pot. Okay. Why is that not there? Well, by the time we got to Christmas, it was 50-50 already. That had dropped from 80 to 50-50 and was getting worse, right? Because if they keep counting that number in the context of 85% uptake in the vaccine and people are still dying who are taking the vaccine, that's going to go up. And so that's the deal, what they were seeing, this sort of partial truths, hiding those things in sometimes in plain sight, right? But that idea of only counting yourself as vaccinated until 2 weeks after, I think that has been a huge part of the statistical anomalies and some of the statistical representations we've been seeing.
Well, and that was kind of the argument that was thrown at me multiple times. Like, well, even when I would reference the public health information, like go look for yourself, sometimes I would get the rebuttal, well, it says like 80% of people who've died or more have been in the unvaccinated. I said, okay, but that's also accounting for an entire year when the products weren't even available on market, right?
I've done the calculations because you can go back on the way back machine and you can pull up the statistics at a given date, right? Mm-hmm. Assuming they don't go back and scrub those too, which they sometimes do. But so you can see how many people, if you just start counting the death rate in June, like when you get, which is reasonable because you're about 50-50 at that point. You don't get that same favorable representation with respect to death in the vaccine. It's very much heavily in favor of remaining unvaccinated at this point. Those percentages have continued to creep the other way, which is the only reason why they've taken them off the website. I mean, one of the main funding agencies in Canada for health, the CIHR, they gave out millions of dollars of research funding for vaccine hesitancy a couple of months ago. And most, pediatric ID programs in Canada got $50,000 grants to improve hesitancy. Well, if you want to improve hesitancy, stop taking data off your website, stop going to court to try to prevent the release of these data, engage people who are pointing to your own data and to peer-reviewed data, as opposed to just blanketing them with misinformation, disinformation, when it is demonstrably our own public health officials and Prime Minister who have time and time again been shown to be incorrect with respect. I mean, our Prime Minister last week in Davos at the World Economic Forum stated that if he could get the last 10% of his population vaccinated, we could get to herd immunity and the pandemic would be over. I mean, what kind of nonsense disinformation is that? If the majority of people who are right now getting Omicron are triple vaccinated, it doesn't matter if the last 10%. And the people that were censored who were really, really smart on this, Professor Gert Vanderbosch, who, with respect to vaccines, worked at Pfizer, Dr. Yeadon, another person who was in industry and also very, very bright. Professor Luc Montagnier, who won the Nobel Prize for discovering HIV. These people have been warning about the possibility of negative vaccine effectiveness and about antibody-dependent enhancement. And the reason that they did was because of about a dozen animal studies that showed in respiratory viruses that with subsequent exposures to the virus, those animals that received the vaccine died. So it hasn't been like this sort of far out consideration. The FDA and CDC recognized it was something that they needed to watch for as well. Those people, including Gert right now, are saying that our best chance of getting through this is to keep those who are unvaccinated, to give us a chance to actually develop immunity and act as a sinkhole for these escape mutants that are happening right now, right? So I would say that it's time to think about some of these people that over 2 years have proven right in their predictions and do a hard stop like other countries have already decided to do, especially when you're talking about healthy young people and these shots.
Well, I mean, I would suspect with the multiple waves that we've already gone through, and with how widespread Delta and Omicron were, that probably the vast majority of people in Canada, vaccinated or not, have already developed natural immunity, right? Or would have been exposed to it.
We've got studies showing that. There's a BC study showing that there's immunity in over 90% of the population at this point.
Is that Dr. Pellick?
So Steve Pellick, it's not his data. He's got another impressive database where they've been taking samples from people prospectively over a number of years, and he's been since the pandemic, and he's been following this. He can show you the genetics. He can, in a lot of detail. He's the chair of our scientific advisory committee at the CCCA, and he's a professor at UBC. So he knows what he's talking about. But nonetheless, yeah, over 90%. So we knew at the beginning that there were probably 30% of the population that had some cross reactivity to prior coronaviruses, which is one of the reasons a lot of the models were nonsense. But even, the reason I started smiling when you were telling me that was that a couple of weeks ago, there was a model that was published in the Canadian Medical Association journal by this Dr. Feisman, who
I know the one
was, he was previously a member of the Ontario Science Table. So that's the main group that's deciding COVID policy in Ontario. And he's also received lots of funding from big pharma, including Pfizer. And so the CMAJ decided to publish this model that he had created, showing that it was the unvaccinated that were spreading the virus, that we were disproportionately giving the virus to other people, right? And that was run, by the time that was published, it made it everywhere in the world. I saw it, colleagues showed me this from different places in the world. It was one of the most, you hate to, you don't want to use the word fraudulent, but it's close. It's so bad. And when we looked at it, I'll give Dr. Feisman credit. He made available his model. And so we were able to look at it on the CCCA, and you can see now that there's like 10 or 12 different rebuttals to Dr. Feisman's letter on the CMAJ website, just destroying it from all different perspectives of being just so, to me, I find that, as a obvious example of disinformation as there can be. You just have to look outside the window to see it's raining, to see that it's raining here. Don't tell me a model to say, well, even though it's raining outside, it's not raining. The real world data is showing that the triple vaccinated, the vaccinated are the most likely to have it. That's what the real world data is showing. So don't publish this nonsense model telling me that the unvaccinated is not. Dr. Bridle was able to change one variable in that model. And by changing that one variable, the whole model flipped over. And it was the vaccinated driving transmission, which was consistent with what our current effectiveness data is in the real world. And what was that variable? It was the percentage of people that have been exposed to the virus. And in his model, he predicted 20%. And the reality is it's over 90. And if you put it in at 80, the results flip.
Yeah, and that's what Dr. Bridle did, right? He conservatively put it in at 80%.
Right.
Yeah. Okay. I saw his rebuttal.
And he flipped the whole results. And so, and then, a couple of other very, very smart rebuttals there, including some of the people that have been showing the all-cause mortality. We have people on our committee who are modelers, who are statistical modelers, and so it was really, really unfortunate to see that made mainstream media everywhere, and it was used to beat down on 6 million, Canadians who have continued to exercise, bodily autonomy, despite threat of career ending and all sorts of other things. To have that being pushed out by the Canadian Medical Association journal, who I bet you, be interesting to see where their funding comes from as well. I found that very disconcerting, because you at that point, it's easy to know that data is not true. It wasn't consistent with what you were seeing in the Ontario. So, it's like the initial models that came out of the Imperial College of London by Nigel Ferguson, up to 6% all, excess more, 6% all case mortality, and these things that have shown to be, totally wrong. Let's ignore real world data for a model. Give me a break.
Two things. One is more of a comment, one's a question. But the Fissman, my initial thoughts when I read that Fissman article, of course, because it was all, like you said, went viral in mainstream media. But of course, they would never publish Dr. Bridle's rebuttal. But regardless, when I read that, my initial reaction was like, that's not a very good, that's a pretty poor assessment of the level of protection. Like if everyone who's, and we've all seen that viral video of that nurse giving that speech, but like, if you're worried about getting the virus from me and you've taken 2 or 3 doses, isn't that a subconscious admission that it doesn't provide any really adequate protection?
Of course. I
Right?
mean, how is it? Yeah. I mean, if and I have friends now who still think this. I mean, physician friends who still think this. It's remarkable. If you've taken 3 shots and got the vaccine and got the virus anyways,
Mm-hmm.
how is it because of the people who didn't take the shot? I mean, because we so because I didn't take the shot, you took 3, you got the virus, it's my fault. I mean, we know that the idea of herd immunity with respect to this virus is Dina Hinshaw, Dr. Dina Hinshaw, our chief medical officer, I mean, she'd say this was endemic back in September. The World Health Organization said it was endemic back before Christmas. It's just Trudeau out there, saying that this thing is, so the idea that if we got enough people vaccinated and this thing wouldn't spread, that went out the window when we found out that these vaccines don't prevent transmission, right? And so the other thing that you hear from people is, they're still blaming somehow that the people who didn't take it, as opposed to blaming the vaccine that didn't work, maybe, is, oh, well, if I hadn't taken the vaccine, I would have been hospitalized and died from the virus.
Mm-hmm.
And I'm hearing very smart people say that, and it's complete nonsense. And, that may be the case in certain instances, but let's recall that the death rate and serious illness disease rate has not changed since before or after vaccines. The all case mortality that has fluctuated up and down a little bit in Alberta and Canada is not like when the vaccines came, all of a sudden people stopped dying and all the case mortality dropped, right? We know that about less than 3%, and that's probably inflated quite a bit because we don't have the right denominator. But if you look at the Alberta public database, and I think I sent you that figure as well, about 3% of cases ended up hospitalized, less than 1% ended up in the ICU. That was before the vaccine. So, your risk as a healthy 40-year-old person who's skinny and doesn't have diabetes, and has a healthy immune system, your risk from being hospitalized before the vaccine was less than 1%, right? Mm-hmm. So, the idea that this thing saved you is inconsistent with the idea that you were going to get saved by your own natural acquired immunity, your own natural immunity, with greater than 99% success rate, even prior to this vaccine, right? Mm-hmm. And if that data that's emerging is in fact, and it's not just the Canadian data, that negative effectiveness data, that's been seen elsewhere. It's been seen in the UK, it's been seen in Denmark, it's been seen in Iceland, it's been seen in Japan, it's been seen, for instance, in the US. The weekly morbidity mortality reports have been showing that the places with the highest vaccine uptake have had the highest COVID rates. That goes back to the fall. This is data in multiple places, right? So if it really is true that there's negative effectiveness, that you are more likely to get this moving forward with subsequent exposures, especially if you continue to take these shots, then the idea that it prevented serious illness becomes moot, because you may not have gotten it if you didn't take it, right? So that's where we're at with the real literature. But I mean, I had a colleague who told me the same thing that happened to your brother. Mm-hmm. A healthy, skinny athlete who does triathlons, who's also a physician. In his bed, his chest was on fire for 3 days and never got a diagnosis of myocarditis, right? And got the 3rd shot, right, like he was supposed to in the fall or going into Christmas. And then he had Omicron that knocked him out for 3 days in February, right? Mm-hmm. So now he's got vaccine-induced myocarditis likely that he suffered months ago, and he still got Omicron anyways. Mm-hmm. And yet his comment was the same thing. Well, I didn't die from this because I got the vaccine, right? But you've got to put it in the context of the numbers that we've had. Less than 1% of all cases end up in the ICU. The risk of death if you are 60 and healthy and under is in a fraction of a percent. That is the reality of this thing. And then you've got all those black box unknown that we don't know. Like, I mean, mm-hmm. including, we don't even have 6-month data from the 3rd vaccine, mm-hmm. follow-up. We don't have that. And just to make you that much more comfortable with Pfizer, I mean, one of the things that Pfizer did after the 6-month data was they unblinded the trial. meaning the patients who had received placebo all got vaccine. So we were supposed to get phase 3 long-term longitudinal data, which is usually in the US, you can't get something off emergency use authorization until the phase 3 long-term data is available. And for Moderna and Pfizer, it was fall 2023 and 2022. But the reality is that data is nonsense because everybody got the shot. So we don't even have that data, right? And so, with respect to, okay, following people who got the third shot over time, you don't have that stuff either, right? So it seems like there is increased risk with time, with exposure to these things. And, in the context of Omicron, and in the context of all those, concerning biodistribution, the idea that your lymph nodes are still pumping this out, the idea that this can interact with tumor suppressor genes, the proof that this can interact with your innate immune system in a negative way. So certain things like toll-like receptors that keep cancers at bay can get knocked off. And the idea that, like, the unbelievably scary idea that this can get into your nucleus. I mean, we should be proving this immediately. Like, we should be, let's check people's spinal fluid, right? Let's get to the bottom of this stuff with everything that we're having. And so to me, that unknown is gone even more concerning. It hasn't gone less concerning.
One question regarding natural immunity. I know I've read some articles. I've seen many thumbnails from the different platforms that I follow. Have you seen any evidence suggesting that natural immunity would make you less likely to transmit than solely having vaccine-induced immunity?
So, I mean, what we saw with Omicron, what we thought, going into Omicron, was that if you had gotten COVID, your chances of getting COVID again were going to be very, very small. And if you did get it, it was going to be mild disease, right? And that's what has turned out to be the case. Having said that, more people got Omicron who had been than you'd expect, who had previously had a virus, so it wasn't as bulletproof as you might expect. The caveat to that is the PCR testing and how many are real cases a year ago anyways, I think. But that being said, the evidence shows that even if you get reinfected with COVID, your symptoms are less. And so if your symptoms are less, your ability to transmit is going to be less as well.
Okay.
And it's the same idea. I mean, with the vaccine, if you measure people in that sort of window of 2 weeks to 2 months, you might find that there is some decrease, at that time. But what we learned through multiple studies, including, there's a Vietnamese healthcare trial. There was another study in Wisconsin. People were looking at the viral loads. It didn't matter if you were vaccinated or unvaccinated, you could still generate that still sort of high viral load in the back of your throat. So, some people who have been vaccinated are going to still get COVID, and some of them are going to have mild disease, some of them are going to have major disease. But, a nice clean study answering the question that you're doing is not done as I'm aware of. One of the best places, I think, to look at for the natural acquired immunity story, if you look up Dr. Paul Alexander's Brownstone article, that it's a sort of a living document. I think he's up to over 150 trials showing that natural acquired immunity is a thing and often superior to the vaccine induced immunity. And that's been around for a while, but I think he's up to 150 papers on that one. I mean, we knew before coronavirus 2, SARS-CoV-2, there was a paper that I cited in my letter in September. Patients who had gone SARS-CoV-1 in Ontario, for instance, back in 2003, there was a Nature paper showing that they still had cross-immune reaction to SARS-CoV-2, to the envelope protein of SARS-CoV-1. So people had gone to SARS-CoV-1, had formed antibodies to not just their receptor binding domain, but also the envelope. And 17 years later, right as we were dealing with SARS-CoV-2, those patients were tested and they were still immune. So we know the ability of the immune system to recognize that. And, to that point, the vaccines are still contain genetic material for us to produce in our bodies, the original spike protein from Wuhan only, not the whole virus, not the envelope protein, the part of the virus that changes the most, the receptor binding domain. The envelope is the most conserved area. It would have made a ton of sense to include some of the protein in the envelope, in addition to the spike, for instance, perhaps. So, the idea that you're going to reform a robust and comprehensive immune response to SARS-CoV-2 virus through the vaccine that only generates antibodies to the spike protein itself, was a bit of a stretch, I thought. The other thing that was a stretch was the idea that, something that's brought to market in 3 to 9 months, a genetic vaccine, first time we've used it, changing the definition of the vaccine, experimental by all standard considerations of what's experimental, is going to somehow be outperformed. Is somehow going to outperform, or several millennia of our God-given immune systems. Right? It seemed far-fetched.
Okay, I'm going to wander into a little bit of different territory here. We've talked a lot about, you've given some incredible information about the medical science aspect. So now I'm going to wander into the territory of who knew what when. And I think that's something that people question me on quite often, but I don't have an adequate answer. So, and I mean, please, if there's anything that you're unwilling or uncomfortable with answering, just say so and I'll leave it alone. But based on everything that you know and that you've seen and experienced, do you think has anyone in Alberta Health Services or Public Health Canada that you're aware of specifically been made aware of all of the safety and efficacy concerns?
Yes.
Okay. And are you?
They've received letters from lawyers that have included some of the points that I made with respect to the for instance, injecting 1 million children to save one life in the Pfizer data, and the myocarditis risk that that's been pointed out to chief medical officers and heads of Alberta Health Services through lawyers. I mean, ultimately, those who are sort of in charge of COVID policy at local children's hospitals, for instance, even including my own, I've had my letter. Every member of the College of Physicians and Surgeons who counsel received my letter. The Prime Minister has received thousands of letters with respect to these things. So the warnings about this stuff and about this reality have been there, and they've been there since at least the fall, if not before that. I mean, some of these people were speaking out for sure 1.5 years, 2 years ago. Paul Alexander being one. I mean, his story is really remarkable in the sense that this is a guy who's an expert in clinical trials and in evidence-based medicine, a professor at the university, was in McMaster University, and he worked for the World Health Organization in Europe at the time COVID broke out on exactly this type of policy, and was recruited into Trump's administration to help advise on COVID policy. And he just published on a Substack recently that he had sent a letter to the FDA and the authorities in the U.S. government before these things had rolled out in Canada. The data that he was looking at showed that we were going to hurt kids more than we were helping them. And he wrote a very comprehensive letter to the powers that be expressing that. And he was told that if he didn't redact that or change that his life was going to never be the same, which it hasn't. And he never redacted it. So people within the U.S. Administration, because a lot of the Canadian officials are following FDA, who they defer their thinking to the global health authorities. There is firsthand evidence that those health authorities are seeing that. What's even more concerning, if you listen to any of the testimony from the Department of Defense whistleblowers on Senator Johnson's, there's a different database that they are using.
Mm-hmm.
That database is sent to the CDC. They get the data. And so they're sitting on the real data that shows that these things are killing people.
Mm-hmm.
If you believe what those whistleblowers are telling you, backed up by their defense. For instance, they made a statement that in the fall, when the CDC was telling everybody that 80% of the people getting the virus were the vaccinated and dying from the vaccinated, was actually the opposite.
Mm-hmm.
So they're you can't even necessarily trust these numbers. But my point is, there are even, a big issue that we found ourselves in is that, like, some of the things that we should have access to, we don't have access to. But those databases do exist, and whistleblowers are suggesting that the highest ups, even within the military, so the Department of Defense, right? I mean, they keep very close records on their soldiers. They go through annual assessments. They're seeing this uptake in all-cause mortality in their own databases, right? So in terms of who knows these things, it goes right up there. In terms of who knew what when, I mean, I don't know the answers to all of this stuff. I mean, the only thing that ends up making sense is that they're that people are all sort of following, the same global health narrative. There are people that have made a lot of money on this. There's no doubt that the financial interests are huge. Pfizer, $34 billion or whatever. More billionaires have emerged in the last 2 years than ever before, even though we've absolutely crushed our middle class. So people have gotten rich off this. And so that's a pretty good incentive as well. And as I sort of alluded to throughout the interview at different times, that big pharma money has infiltrated medicine at multiple different levels, including the review process at peer-reviewed journals. So what I have seen firsthand is that there seems, and this goes along because myself and 3 other physicians did take out a lawsuit against our employer in Alberta for the vaccine mandate before this was dropped. What we sort of learned was that the decision-making process is happening at the top by a few people, right? So you've got the equivalent of the Ontario Science Table. There is the Alberta Scientific Advisory Committee on COVID-19. You can see their reports, for instance, on ivermectin in February 2020, and sort of see what they're thinking about these things. Inevitably, they default generally to the global sort of authorities on these things. But when you ask, for instance, just to give what we've been able to obtain, you're interviewing different people under oath. I think I can say this without any sort of issues. The Alberta Health Services, for instance, they're following their scientific advisory panel. Okay, that's who they tell you they're following. The scientific advisory panel is following the global health authorities, generally speaking. Okay, the College of Physicians and Surgeons are supporting AHS by enforcing, vaccine mandates or whatever amongst their physicians. And they point away, they defer to AHS for guidance, and AHS deflects it to the Scientific Advisory Committee. If you ask them, for instance, okay, I don't want to take this shot, and you're making me take this shot to keep my job. If I wake up tomorrow with transverse myelitis and I can't work as a physician anymore, will Alberta Health Services cover my injury? And the response we eventually obtained was no. That this is a discussion between you and your family physician or pediatrician, and you accepted the risk when you accepted the vaccine. And it got even so everybody's kind of pointing fingers at each other in terms of who blames who. And most doctors out there don't realize that the powers that be, when they're under oath right now, are pointing the finger at you.
At the physician.
At the physician, while they have a gun to your head telling you that if you don't tell everybody this is safe and effective, you're going to lose your license. So that's sort of the circular argument that we're sort of seeing. These people legislatively are supposed to be looking at them, are supposed to be governing themselves, police themselves. So until we have a citizen's inquiry, we get some sort of public inquiry into what's happened to find out who knew what when, like you suggest. We're not going to be able to move on, because people's confidence in the medical system has been absolutely devastated. There are definitely people who still believe it. And I think there's a lot of physicians who don't realize that it's been crushed the way it's been crushed, but I can tell you it's been crushed. And the only way, especially, if you look at the people who've been injured by this thing or who've been devastated by lockdowns, as you try to force third and fourth shots to get onto a digital ID, a vaccine passport, whatever you want to do it, these people are going to be reticent to do that based on what they've experienced themselves, because they don't trust it. It's not hard for people without a medical degree to see, okay, when you go to court to try to hide things for 55 years, like the John F. Kennedy assassination, that maybe there's something to see here, right? If you had the data to shut up people like McCullough and Geert Vanderbosch and Robert Malone and the hundreds of others or dozens of others have been very, very vocal, you would have shown it to us already, right? That is not being the case. It's just just isn't there, right?
Yeah, well, I mean, when I look at the information, and I've spent countless hours reading, but also listening and watching, like people like yourself and all the experts that you've made reference to in this interview. I've been following them and more, and it's impossible for me to think that our chief medical officer, like Dr. Tam federally, Dr. Moore in Ontario, Dr. Hinshaw in Alberta, like they must know that these carry real risk. They failed to prevent infection transmission, and yet they're still helping propagate that narrative that you have to do it, you have to do it, you have to do it. And we're going to strip you of your ability to work and participate in your children's lives and your ability to travel unless you comply. Mm-hmm. And so I guess I'll ask, like, do you think there's any way that they are just prey to the mass formation, or that they are fully aware of the harm and the ineffectiveness, but they're complicit in the narrative anyway because of fear or financial interest? I don't know.
Yeah, and at this point, it'd be in your CYA mode, right? Cover mm-hmm. your own butt here, because the same people who've been leading the charge authoritarian wise on COVID last year are the same ones who are telling us to quadruple down on the same strategy that has failed. I mean, mm-hmm. You can't. There's been, when this thing came out, you said it would stop transmission. You couldn't get COVID. This has been a fail. Mm-hmm. Bill Gates has called this a fail. I mean, mm-hmm. This is a fail. I think that there are some people that where the Kool-Aid and the mass formation is so thick, mm-hmm. that the self-fulfilling prophecy is so thick that they really don't see it. There are definitely some people in authority positions who see it. Mm-hmm. And one of the things that is interesting about Dr. Tam is that she sits on one of the World Health Organization's committees. Mm-hmm. So here we've got somebody whose job it is to look out for Canada's health, and she sits on a subcommittee of the World Health Organization. And the World Health Organization, it's taken me a long time to, in the last, I guess, year, I've done a 180 in terms of I used to have, high reverence for them, maybe inappropriately, but notwithstanding, what I learned, and I include this in my letter in September as well, but in 2009, when the swine flu pandemic mm-hmm. Emerged, they being WHO, had a whole bunch of contracts with countries internationally that if it became a pandemic, that would kick in contracts for swine flu vaccines. Mm-hmm. They changed the definition of a pandemic in order to activate those contracts. Mm-hmm. And in a documentary that you can see and Google, the WHO was found criminally responsible for acting fraudulently with respect to their actions with the swine flu. I mean, they literally changed the definition of a pandemic in order to force countries into kicking in their contracts with the vaccine. And what's really interesting about that that video, they interview a guy who was in charge of the propaganda, a Belgian man, when it came out, and he's giving an interview, he's giving a talk and telling people his strategy to ramping up fear in order to get people to comply. And he shows at one point, I even use this cartoon. It was a picture of the Calgary Flames, a hockey player, because the Flames had, apparently tried to jump the queue for the swine flu vaccine. And so he was like, look at this. It's under so much demand that our NHL, people or elites are trying to get access to this vaccine before it happens. He explains exactly the process through which they brought out the propaganda narrative with respect to COVID. And so the idea that the WHO has got our best interests at heart, I mean, they were, when the top funders of the WHO, United States, and then Trump temporarily removed funding. Then it's Bill Gates, like $250 million, his Gates Foundation. So that's a conflict of interest when you consider his financial investments in the vaccines themselves. And then China's down in third, right? And China ended up playing an extremely huge role in Tedros, who's not a physician, who's the head of the World Health Organization, being elected, right? And it was for those reasons, including that, and that they seem to be playing these games in terms of what is and what isn't a pandemic, that there were financial interests for them to be calling a pandemic, that Gates, clearly had a financial interest, that's part of why Trump, pulled the funding at that time. So they don't have, they are infiltrated by commercial money. There's just no doubt about it. And they have been found criminally guilty for their actions with respect to the swine flu. And so, I just don't give them we can't give them the benefit of the doubt anymore. And with respect to this particular one, I mean, a lot of your listeners probably are aware of Event 201, which was an organized simulation game of coronavirus that was done in September 2021, just 2 months before the coronavirus came out. And they simulated, it was all the main people, World Health Organization, the Chinese government, US intelligence services, Johns Hopkins University. They worm gamed out how they would, and the video of this is just remarkable. You want to hear, I mean, the Chinese delegate is talking about, there's going to be a misinformation about where the virus came from, and that this didn't just jump species, but that this leaked from a Chinese lab. We need to be prepared to deal with that misinformation. I mean, it was incredible how well that they predicted these things, and yet they don't have any treatments 2 years out. Their ability to predict and figure out. I mean, Fauci is on video in 2017 saying, I've got this video clip. He's giving a talk saying before Trump's first term, and this is in 2017, he's going to face a global pandemic. Right. And now we got Bill Gates warning us that we're going to see another pandemic soon. He just wrote a book that was published, Seeing the Next Pandemic. And when he's asked about these things, he giggles that we're going to take the next one more seriously. I mean, I don't know. But it does seem to be that the ultimate decision making for this is happening at a very high level globally, and that Western countries are following suit with that narrative at all costs.
Well, I know, and I think that Event 201 you mentioned, I think that was actually hosted by the Bill and Melinda Gates Foundation. And then when you mentioned the I would assume it would be probably some fraud, like offenses related to fraud for the WHO for the swine flu. I mentioned earlier the Ontario Pandemic Response Plan. This is influenza. Written last updated 2013. That was the last one that we had. The Canadian Federal Plan 2018, and then I read both of them, and then I looked up Dr. Theresa Tam's bio. And when you read the introduction for the Ontario Plan, the federal plan, and Dr. Tam's bio, I think it's like if you search her and you find there's like I think it's like the third search result has something to do with women in medicine. almost the exact same language is used in all three of those documents, her bio and those the Canadian plan and the Ontario plan introduction, and it's specific to best practices and lessons learned from the SARS-CoV-1, like the original SARS outbreak and the swine flu, and then and other pandemics. But they specifically mention H1N1 or the swine flu and the original SARS outbreak in the early 2000s. And so that was another one of those little drop in the evidence bucket, that she knew exactly what these the content of these plans, she absolutely must have known about and was probably instrumental in forming both of them.
Yeah, no, I agree. Just given her position at the World Health Organization. I mean, in the fall, I was able to cite a paper that came out it was either October or November 2019. So about 2 months before COVID, right after Event 201. This paper included investigators from the Wuhan lab, including the so-called Bat Lady. And this particular paper, they showed how to cause enhancement of coronavirus. So they were showing that they could enhance the virulence and infectivity and essentially create antibody dependent enhancements of the virus of SARS-CoV this is just 3 months before this all came out. Hey buddy, it's supper time, buddy? Want to say hi? Yeah, so we've got a paper that showed that they were manipulating the SARS coronaviruses in a way to make them more infectious, and this was published 3 months before that case. And I just watched a podcast by Dr. John Campbell. I don't know if you know of him, but he's been interesting to listen to over the last couple of years. But it shows that the same Wuhan lab has been working with monkeypox, and they've published papers on monkeypox. So it's these coincidences are a little bit incredible.
Yeah. Someone that I've become friends with, who formerly from the intelligence community, said one time might be a coincidence, 3 times it's not a coincidence anymore. It's a pattern.
That's right. That's right. Yeah. And the other one, right? Albert Einstein, the definition of insanity is doing the same thing over and over again, expecting a different result.
Yeah.
And here we are using the same vaccines, the original spike protein from 2 years ago, and still talking about lockdowns and masks when we have evidence to show that those things have caused harm.
Well, and those, again, coming back to Theresa Tam, obviously knowing the plan, my interpretation of those plans, especially after reading David Redmond's paper, Canada's Deadly Response to COVID-19, I went through and checked for myself, and both of them are almost identical. My interpretation is lockdowns were only meant for something that is far, far more deadly, and as an absolute last resort. Masking's not even mentioned, except for a fit tested N95 for a healthcare professional treating an infected patient. Developing early outpatient treatment acting under the precautionary principle, where you can't wait for certainty, is absolutely part of both of those plans. And then when it comes to immunization, it's talking about influenza, but immunization, it has to match the circulating strain. And so right now, we have just taken our plans that were allegedly based on lessons learned and best practices from previous pandemics and flipped it completely on its head. Yeah. And obviously Theresa Tam would know that, right? That's
right. And you're going back to the Great Barrington Declaration. I mean, that's what these giants in public health and vaccines and epidemiology had said, was that you were, absolutely going to cause more harm than good with these lockdown strategies, and that you were throwing, a century of public health information down the drain. They totally did not. It was not consistent with what you'd expect.
And why? I think that's the question that so many people are asking, and I think we're getting a pretty strong sense as to the why. you've talked about it at length, the regulatory capture, the big money influence, even possibly the mass formation, all could be contributing to that. But it just there, and that leads me to the suspicion that the only logical explanation is that this is all deliberate action, because I just can't believe that many experts on a global scale would get it this wrong when they knew.
I would say that certainly at this point, the decisions to keep unvaccinated people off planes and to keep teenagers out of camps unless they take the vaccines, those are deliberate. And we've got 2 years of data now to show that, right?
Well, and every time they're asked in the House of Commons now what evidence they're using to continue these mandates, they never provide an answer. Right? They say that it's based in science, but they'll never provide the evidence. Anyways, right. It sounds like
I've got to go. The 3 kids have now come down, and, so I got dinner. That's a pretty lucky thing to have prepared for me. So I'm going to go and enjoy that.
Well, thank you so much. Is there any final closing thoughts? I mean, we could go on and on, but thank you so much for your time. It's been over 2.5 hours.
Yeah, no, we talked a lot. I didn't realize it was gone that long, but it's always a pleasure to chat with you. I don't know that I've got, anything else to sort of, summarize all these things other than saying that, we are at less than 40% uptake on the booster right now. And we're heading into a fall season where, things might start to increase again, and there might start to be some pressures on us to lock down, take 3rd shots, 4 shots, whatever. Oh, hi, Charlotte. And that's my 8-year-old, just turned 8.
Oh.
I think people are going to have to make some hard decisions right now in terms of about compliance and whether luxuries like travel and certain things, are you're going to have to make these decisions for yourself, because the reality is, if this was ranked in science, we'd be allowed to fly right now.
Well, thank you so much for your time, Dr. Payne. It's very much appreciated.
All right. Thank you very much.
Take care. Thank you.
Take care. Bye-bye.
Bye.